Thank you very much for being here. It's my pleasure to present the group of República Dominicana. Dr. Ada de los Santos is a pediatric pulmonologist. Thank you very much for organizing this, Ada. So I give you the microphone.
Hi, everybody. My name is Ada de los Santos. Is Dominican Republic pediatric pulmonology. And one moment is the decimal presentation of the bronchitis in the pediatrics patient with single ventricle. Is Diana Gil is second-year fellow for pediatrics. My friend is Juana Mercado Rodriguez, is pulmonology pediatric in Dominican Republic, Santiago de los Caballeros.
Afternoon, my name is Diana Gil, a second-year pediatric resident at Clínica Unión Médica del Norte in the Dominican Republic. This afternoon, it is my pleasure to moderate this very interesting discussion entitled Plastic Bronchitis in a Pediatric Patient with Single Ventricle, with the participation of Dr. Ada de los Santos and Dr. Juana Rodriguez Mercado, both pulmonologists in the city. Okay, these are the topics corresponding to the presentation of our clinical case, where we'll begin by presenting, and then we will discuss a topic mentioning the most important considerations. Okay, so a 13-year-old male patient with medical history of single ventricle hyperflow cardiomyopathy, corrected with Glenn surgery, treated with spironolactone 25 milligrams and clopidogrel 75 milligrams for continued use. And encephalomalacia of unspecific duration, treated with levetiracetam 15 milligrams for continued use. Recurrence episode of pneumonia and bronchospasms, treated with nebulized ipratropium bromide, signs 3-month age, and history of an ischemic stroke 1 year prior. The patient was asymptomatic until approximately 7 days prior to admission, when he began a clinical presentation characterized by a dry cough that later become productive, irritating, and persistent, non-emetic, non-cyanotic, accompanied of moderate respiratory difficulty characterized by rapid and deep breathing with use of accessory muscles and intercostal reaction. So after evaluation and management, it was decided to admit him to the clinical ward. So as we can see in las imágenes de la primera, la del eco. Okay, here we can see the first image where we see the echocardiogram, where we observe heart with apex to the right, common atrium, common atrioventricular valve, trabeculate ventricle to the right, small and okay, figure 2 checks X-ray PA, where we observe increased density is observed in the right hemithorax with partial loss of the right cardiac silhouette and right pleural effusion. Next. So here we have a timeline of the most important events regarding our patient prior to admission. In the first 3 days, he develops a persistent cough. Subsequently, this cough becomes productive, and there is an increase in secretions. From 6 to 7 days, he develops moderate respiratory distress and present with tachypnea, use of accessory muscles, and intercostal retractions, which is why his admissions is subsequently decided upon. The methodology in this study, an observational, descriptive, longitudinal, and retrospective case, was performed based on comprehensive review of medical records. Data were organized chronologically to analyze clinical progressions and therapeutic response over 24-month follow-up period. The patient was evaluated for recurrent pneumonia, remember that, with pulmonary function tests reporting the following values. Here we can observe the values before and after bronchodilator use. Below is our legend explaining the meaning of each of these abbreviations, where FBC, forced vital capacity, FEV1 for expiratory volume in 1 second, FEV1 FBC rated of forced expiratory volume in 1 second, and forced vital capacity, DLCO, diffusion capacity of carbon monoxide in the lungs. Here, where we can observe a non-specific pattern with decrease FEV1 and decrease of FBC. Siguiente. Okay, here we can see the post-bronchodilator test where we do not see a bronchodilator response. So subsequently, the LCO, carbon monoxide diffusion capacity test, was performed. Siguiente. Here we see a normal test. However, we can see the expiratory volume did not reach 19%, is 44%. Siguiente. Okay, because the patient continued to experience respiratory symptoms despite the use of bronchodilators and timely antibiotic therapy, a bronchoscopy was performed, revealing bronchial malaise and abundant thick mucus secretions consistent with plastic bronchitis. Siguiente. Siguiente. The findings from the bronchoscopy were as follows: bronchial malacia, thick mucus secretions, and bronchial cast. Here we can, number 3, we can see a bronchial cast expectorated by the patient. And figure 4, an image from the bronchoscopy showing bronchial malacia. Okay, so plastic bronchitis represent a rare but serious respiratory of bronchial cast composed of fibrin, mucin, and inflammatory cells that obstruct the airway. This condition demonstrates strong associations with congenital heart disease, particularly in patients with calvo-pulmonary connections, including the bidirectional Glenn procedure. Okay, these inflammatory cells further contribute to mucus obstructions and create a self-perpetuating cycle of airway damage and cast formation. Siguiente. The incidence of this pathology has been described in 6.8 out of every 100,000 people, estimated prevalence in pediatric population. The disease occurs predominantly in children, but has also been reported in adults. Males appear slightly more affected than females. Siguiente. It can be caused by various factors that specifically compromise different systems, such as congenital heart disease or inflammatory process or infections triggers. In the case of our patient, we see Glenn surgery as an important antecedent. Therefore, it is very important to understand the physiology of this. The Glenn procedure is a palliative stage in the surgical management of single ventricle physiology. The operation connects the superior vena cava directly to the pulmonary arteries. Routing superior body venous return passively into the lungs without a ventricular pump. So in gland circulation, pulmonary blood flow depends entirely on passive pressure gradients rather than ventricular ejection. This creates elevated systemic venous pressures, particularly in the upper body, and abnormal pulmonary hemodynamics. Siguiente. The clinical presentation of this patient can be divided into 3 groups: respiratory manifestation, systemic manifestation, and physical examination. Among the respiratory manifestation, we can find dyspnea and tachypnea, expectoration of rubbery branching cast, persistent or paroxysmal cough. Among the systemic manifestation, we can see hypoxemia and cyanosis, exercise intolerance, recurrent respiratory infections, and finally, on the physical examination, we can find decreased air entry and possible cyanosis or respiratory distress. Clinical complications are positioned here in relation to the progression of the disease. In number 1, death by asphyxia. In number 2, acute respiratory failure, massive airway obstruction, recurrent atelectasis, and intermittent segmental obstruction. Serial imaging demonstrating shifting atelectasis support the diagnosis, but it's important to mention that normal chest radiographies do not exclude the diagnosis, as CAST may cause bronchial obstruction without immediate parenchymal change. Pasa la siguiente. Okay, furthermore, high-resolution computed tomography shows airway falling defects, breaking structures within the bronchi, and air trapping patterns. With magnetic resonance lymphography, we can visualize abnormal lymphatic flow pattern and identify thoracic duct abnormalities. Okay, the bronchoscopy is the gold standard. Flexible bronchoscopy provides definite diagnosis by directly visualizing and extracting bronchial cast. The procedure serves both diagnosis and therapeutic purpose, allowing cast removal to relieve obstructions while obtaining material for histopathologic classification. Number 10. Casts can be classified into 2 types, types 1 and type 2. It's important to mention that most casts in gland patients are type 2, reflecting their lymphatic origin. The differential that are as follows: fibrosis, bronchial foreign body, severe asthma with mucus plugging, infections, bronchitis, and sickle cell disease. The initial stabilization of these patients involves several factors, including respiratory support, bronchoscopy, bronchodilators, and hydration. These are the therapeutic options recommended by the various reviewed guidelines. Among the most frequently mentioned are the following: aerosolized tissue plasminogen activator, mucolytic agents, macrolide antibiotic, and corticosteroid. Okay, here we have a summarized algorithm that covers the recommended multidisciplinary management with 7 important points. Point 1, clinical recognitions. Point 2, diagnosis confirmation, hemodynamic assessment, lymphatic imaging, initial medical therapy, interventional therapy, and finally, the surgical consideration. Remember that coordinated multidisciplinary care is essential establish clear communication pathway between specialties, and create individualized care plan, educate families on warning signs requiring urgent evaluation, including increased work or of breathing, decreased exercise tolerance, or visible cast expectoration. Remember that plastic bronchitis represents a serious but increasingly manageable complication of lung circulation. Successful management demands more than medical knowledge. It requires systematic approach incorporating bronchoscopy diagnosis, hemodynamic optimization, advanced lymphatic imaging, target medical therapy, and when necessary, interventional or surgical treatment. Remember that no single specialist can manage this condition alone. Thank you so much for hearing me and for your attention.
Maybe I can have one very simple. But probably you said that, but so I'm not sure. What about the spirometry after the procedure, after bronchoscopy? So did you show it? So you saw an improvement in spirometry. Can you follow this guy with spirometry?
No.
So this spirometry improved?
No.
No.
We see non-specific pattern with decreased FEV1 and FVC. In the bronchodilator test,
I wonder if I could say a few things.
This spirometry is post bronchoscopy.
After bronchoscopy.
Pre-bronchoscopy, specific in a specific pattern. Post bronchoscopy, in a specific pattern. So, yeah, I don't know.
I wonder if I could clarify a few points. Let me discuss a little bit about, that was an excellent presentation, but I need to clarify a few misunderstandings. You mentioned the classification, and Mike Sear described that not in 2021, but in 1997, with only 9 cases. And the terminology type 1 and type 2 have not been used for 20 years for a couple of reasons. First, the numbering system of 1 and 2 are not at all descriptive. The second reason is that all 9 of his cases had exactly the same type. And the third is that there is no difference in inflammatory response. The current nomenclature is lymphatic plastic bronchitis, which is what we see here, or eosinophilic plastic bronchitis, which is more in common with eosinophilic esophagitis than with asthma. As you showed, your patient had primarily restrictive disease, which is consistent with this. We don't have acellular and inflammatory casts. That was abandoned in 2015. There have been over 150 cases reported in our international registry. So the current terminology is lymphatic, and I should point out that these casts do not contain any mucus, they have no mucin, and they have no fibrin. That's been carefully studied with specific antibodies in more than 20 cases. These contain congealed lymph, and it's due to lymphatic leak within the airway. This is the common cause that we see in congenital heart disease with single ventricle physiology, but it's been reported in patients with other primary lymphatic abnormalities of the chest, including in adults who have had lymphatic tumors of thorax. It is due to abnormal lymphatics that then leak. The diagnosis, as you mentioned, is made not by bronchoscopy, but by dynamic magnetic resonance lymphangiography, or DMRL. And the treatment, these patients do not respond to Dornase. They don't respond to TPA. They don't respond to salbutamol or to steroids. The treatment is ablation of the aberrant lymphatics, and that's done also through lymphangiography. Just a few things. To remove these casts bronchoscopically, they're incredibly slippery, and the treatment of choice for that is using cryo, where you actually freeze the cast onto the bronchoscope and then remove it. So I should also mention, in terms of distribution, there is no sex preference, male to female. It was almost identical in our large registry. It has not been reliably associated with adenovirus, although the eosinophilic form has been associated with influenza H3N2, which is bird flu, and it's also been reported to cause casting in some birds who become ill, interestingly enough. So in summary, this is a lymphatic disease, particularly in these patients with congenital heart disease. It's dramatically underdiagnosed. Is associated in these patients with protein-losing enteropathy, which is also a lymphatic disease that can be treated with lymphatic ablation. In other patients, it could either be lymphatic or it could be eosinophilic in nature. For those that have eosinophilic disease, it is not treated like asthma, but some of the biologics appear to have a profound effect in reducing the casting. One other final comment is the literature can be very confusing because there are a number of publications that have confused sputum plugging or mucus plugging with plastic bronchitis. Absolutely characteristic was the image that you showed. It's a beautiful image of branching casts. That's what you need to see in order to make this diagnosis. Thank you for allowing me to clarify some of these things.
Thank you for your comment.
Thank you very much, Dr. Bruce, for clarifying that. This is very interesting. I don't know if there's somebody else that wants to make any questions, or you can write it, or perhaps someone else that wants to raise their hand. No? Great. So thank you very much, Ada, Diana, for presenting this. Thank you, everybody, for being here. And we wait you for our next clinical case. If there's nothing else, nobody wants to say anything else, see you later.